We have discussed different types of pneumonia, how to empirically treat pneumonia, how to de-escalate to narrow definitive therapy. Now, let's develop a patient-specific plan for prevention of pneumonia. Remember that VAP is the most severe type of pneumonia with mortality rates as high as 30%. So we should have ventilator bundles in ICUs in order to prevent ventilator-associated pneumonia. This includes the use of oral antiseptic like chlorhexidine, to wash the patient's mouth. Elevation of the head of bed to decrease aspiration. Daily interruption of sedation is important to reduce the time to extubation. So the longer a patient is intubated, the higher the risk of getting a ventilator-associated pneumonia. There are also silver-lined endotracheal tubes that can prevent a biofilm formation. Some of these organisms can form biofilm, and then it's difficult to get rid of them. And of course, PPIs are usually associated with higher pneumonia. So when we can, for stress ulcer prophylaxis, we should use H2 receptor antagonists instead of PPIs. Now, from the 2007 IDSA guideline for community-acquired pneumonia, it's important that the patients receive influenza and pneumococcal vaccine to prevent influenza and pneumococcal pneumonia. Now, remember that influenza can lead to secondary bacterial pneumonia, so it's important to prevent influenza in order to prevent community-acquired pneumonia. Smoking is also a huge risk factor for pneumonia, so smoking cessation should be a goal for persons hospitalized with community-acquired pneumonia, of course, if they smoke, in order to prevent future episodes of CAP. Now, one thing that's usually confusing is the concept of pneumococcal and meningococcal disease. So let's see what the difference is. So meningococcal disease, such as meningococcal meningitis, is due to the organism Neisseria meningitidis. So Neisseria meningitidis can cause meningitis specifically, and we have vaccines for it. So we have meningococcal vaccine, and there are different types which are beyond the scope of this topic. But it's important to know that when people talk about meningococcal vaccine, they're talking about vaccines against Neisseria meningitidis, which cause meningitis. There's also pneumococcal disease. Pneumococcal disease refers to disease that's caused by Streptococcus pneumoniae. And Streptococcus pneumoniae can cause pneumonia. It can also cause meningitis. So pneumococcal meningitis is caused by strep pneumo. So is pneumococcal pneumonia. So when we give pneumococcal vaccine, we're really preventing or attempting to prevent two diseases, both pneumonia and meningitis. So it's important to let the patients know that the pneumococcal vaccine is not just a vaccine against pneumonia, it's also a vaccine against meningitis. And between pneumonia and meningitis is a lot more likely to kill a patient. So it's a more severe infection. And of course, for pneumococcal, we have Pneumovax and we have Prevnar, and I will explain what the difference is in a little bit. Now, with Streptococcus pneumoniae specifically, all the pneumococcal diseases caused by Streptococcus pneumoniae, majority of them are non-bacteremic. Now, a small portion of them are actually bacteremic, meaning that, if it caused pneumonia or any sort of, upper or lower respiratory infection, they can find their way, in a few patients into the blood. And then the blood can, take the organism to other organs. And then a very tiny portion of these infections are meningitis. Now, let's take a look at Pneumovax and Prevnar. So, Pneumovax has 23 different strains of strep pneumo, whereas Prevnar 13 has only 13. So you might think that 23 is better than 13, but as it turns out, PPSV or pneumococcal polysaccharide vaccine is not as immunogenic. So polysaccharides are basically carbohydrates that are relatively smaller macromolecules. And because they're small, we could put 23 different strains of strep pneumo in the vaccine. Now, they are not as immunogenic. In fact, in children younger than 2 years of age, because their immune system is not fully developed, we don't get any immune response. So it's actually not effective in younger than 2 years of age. Whereas PCV or pneumococcal conjugate vaccine, these 13 strains are conjugated to proteins. And proteins are larger macromolecules compared to carbohydrates. And that's why with current technology, we couldn't fit more than 13 different strains. But we get a strong immunogenic response from PCV, even in children younger than 2 years. So that's why it's actually very effective, and it's indicated for anybody 6 weeks or older. Now, the other thing is, because PPSV has low immunogenicity, it's actually in clinical trials, it actually has not been shown to prevent pneumonia, but it does prevent invasive pneumococcal disease like meningitis. Whereas PCV 13, because it has high immunogenicity, in clinical trials, it's actually been shown to prevent pneumonia itself, as well as invasive pneumococcal disease. Now, let's see who exactly needs to get PPSV 23. Now, there are certain patients. Now, keep in mind that I'm strictly talking about adults. I'm not going to discuss immunization schedule of children. But for adults, so meaning age 19 and older, patients with chronic heart or lung disease like COPD and heart failure, patients with diabetes, alcoholism, chronic liver disease like cirrhosis, as well as chronic smokers, these patients are at risk of having pneumococcal disease. So 1 dose of PPSV 23 is indicated in these patients. Now, once these patients turn 65, regardless of whether they have risk factors or not, everybody needs to get the dose of PCV 13 followed by a dose of PPSV 23. Because PCV 13 is a better vaccine because of high immunogenicity, you give PCV 13 first. So once they turn 65, you get the PCV 13, and then a year later, they get the PPSV 23. So even though these patients got PPSV 23 prior to age 65, because of the low immunogenicity, the effect doesn't last. So they need to get 1 more dose once they get 65. Whereas PCV 13 is a 1-dose deal. So once you get the dose in your life, you don't need to get it again. Now, who needs to get PCV 13 prior to the age of 65? So patients with CSF leak, cochlear implant, sickle cell disease, asplenia, immunodeficiency, HIV, chronic kidney disease, and any cancers that lead to immunodeficiency, these patients need to get a PCV 13 prior to age 65. Now, 8 weeks after they get PCV 13, these patients need to get PPSV 23. And with the exception of CSF leaks and cochlear implant, the rest of these patients need to get another dose of PPSV 23 before they turn 65 years old. And of course, when they turn 65, just like everybody else, just like the general population, they need to get the dose of PPSV 23 because the effects of PPSV 23 doesn't last through age 65. And as I mentioned before, PCV 13 is very immunogenic. So once you get the single dose, you don't need another one. So even though these patients turn 65, they don't need another dose of PCV 13. So this basically is what I explained. This is for general population, people without risk factor. Once they turn 65, everybody needs to get the PCV 13 followed with PPSV 23. Now, if for some reason somebody happened to get the PPSV 23 first, then they need to get the PCV 13 a year later. But generally speaking, people need to get the PCV 13 first. It's the more important vaccine, followed by PPSV 23. And this table basically summarizes everything I explained. You should review this on your own.